everything that we treat based on guidelines. Guidelines are a collection of randomized control trials and other research that has been done, and then a panel of experts come up with recommendations. So I always say that guidelines are written in erasable pen because there's always a patient that we have to tailor and kind of move things around with. But overall, everything is based on guidelines. So I'm going to go over the asthma guidelines here to show you how we treat. So, and how we get to deciding what we decide. This is the first page, and there's also another link in this module that you can actually read it and print it out. And if you plan on going to be an advanced practice nurse, these are things that you print out and you keep in your handy-dandy book and you refer to it. Or those of you that just like to online, you can access the guidelines that way. All right, so what is the goal of asthma care? Number one, we want to reduce the impairment. So we want to treat them because we want them to reduce the intensity of their symptoms, the frequency. We want them to be able to live as healthy of a life, normal of a life as possible, and as well as reduce the risk. We don't want them to have issues. We want them to be healthy, like I said before. So the initial visit, you're going to diagnose the asthma, you're going to assess the severity, you're going to initiate medication, which is what we're talking about here in pharmacology. These patients with asthma should have a written asthma action plan. Is that always done? No, not in reality, but it should be done. Also, a follow-up appointment. So on your follow-up visits, you're going to see how they're doing. How are your symptoms? Are you taking your medications as prescribed? Are you having any side effects to the medications? Are you having any triggers that are triggering an asthma attack? And have you written anything down? So you're either going to maintain what they're on, you're going to maybe increase it or add a medication, or you're going to step down the medication. You're going to review their asthma plan, and then you're going to schedule follow-up. And to expand on the guidelines and what we talked about on the last slide is your asthma diagnosis. So how are we going to diagnose? So we have to go on their history. History taking is 90% of your diagnosis. I can have a patient come in, and 90% of the time, if you get a good history, you know exactly what's wrong with them before they even sit on that exam table to do an exam. So you're going to determine the symptoms and have an idea whether you think asthma, if they have asthma. You're going to ask them about cough, recurrent wheezing, difficulty breathing, chest tightness. Is it with exercise or is it more at night? How about when you get sick? A lot of people have illness-induced asthma. Asthma is not always your typical, what we always thought it was years ago, where you have asthma your whole life or through your childhood constantly and you always need an inhaler. It can be induced by, you can have illness-induced asthma, or some people get bronchospasms from crying, stress, laughing hard. So in all patients at least 5 years of age, you use a spirometry to determine if there's an airway obstruction. Many office settings have spirometry, and there will be a video on what spirometry is, because I think it's good for you to know what these are. That will help you connect it to what how we diagnose it and the medications. So as we said in the last slide, reduce impairment, reduce risk. You're going to monitor the patient, and as you can see, it's kind of nice that guidelines are here, because I can see, all right, asthma, so I'm going to see patients every 2 to 6 months while gaining control, which is an absolute. So if I put a patient on a new inhaler, I'm going to see him back in a month. Sometimes in 2 weeks. It just depends on the severity. Once they're stable, it says every 3 months or 1 to 6 months to monitor the control. Once they're controlled, it can be every 6 months. As far as medications, that'll be on a different slide on how we choose medications to treat. The next thing we have to do is determine what the severity is of the asthma. I'm not going to just give them a combination inhaler with long-acting beta agonist and a steroid if they're only have mild asthma. So, Okay, so first of all, I want to determine if they have mild intermittent asthma. So there's mild intermittent asthma, And then you get to more moderate, persistent, and severe. That's the most common that you're going to see. And I'm sorry for the blurry on the side. Again, there's a link, so if you want to print it out or go along with that, that's fine. But intermittent is greater than, less than or equal to 2 days a week. Whereas if you get to more mild, it's greater than 2 days, but not daily. Persistent is daily, and severe is throughout the day. These are patients that are in the hospital that are intubated quite often because they just cannot get their asthma under control. And it might not be anything that they're doing. It's just they have very severe allergic or asthmatic issues. Okay, so what you do is determine that then. So I do a history on the patient. So how often are your symptoms? How often are you wheezing? If I determine it's about a couple days a week, 3 days a week, then I'll put them more as a mild asthma. I could do mild intermittent or mild persistent. It's kind of on the fence with that. Are they waking up at night? If it's 3 to 4 times a month and 1 to 2, they go in the mild range right here. So as you can see, this is how we determine what category that I'm going to put them in. So we do symptoms, nighttime awakenings, the SABA, that short-acting beta agonist. That is the bronchodilator. That's your Ventolin, your albuterol that you're going to give for immediate relief. Are they having to use that less than 2 days a week, greater than 2 days a week, but not every day? So you take that. Also, how's it interfering with their activity? What's their lung function? Lung function is the spirometer that they're doing in the office, or you can send them for a pulmonary function test. And also you determine their risks, their risk factors. So exacerbations, how long have they been on medications, etc. So this is what we do then. We do step 1 if they're intermittent, and it tells you exactly what to do. If they're mild, you do step 2. If they're moderate persistent, you do the step 3. It tells you exactly what to do. And if we go to this next slide, here we go. Here's the step 1, 2, 3, 4, 5, and 6. And 6 is very severe asthma, whereas step 1 is your mild or your more intermittent asthma. So I'm going to go to down here again. I'm sorry about the blurredness down here, but this is your adults. And as you can see, let's say this patient, I determine that they're a moderate asthma, let's say. And I want to start at step 3. So what does it say I have to do? And I put these things on the side here for you so you know what these acronyms mean. The SABA, short acting, so that's your albuterol. And then your LABA right here, that's your long-acting beta agonist. Short-acting beta agonist, long-acting beta agonist. Remember, long-acting beta agonist usually is in a combination with a steroid. Then we have steroid. That's what this is, ICS, intracorticosteroid. So let's start step 3. The preferred treatment is a medium-dose intracorticosteroid. So I'm going to put them on that, and that's from 0 to 4. I'm sorry, I know I was going down here. So let's go to the adult. A low-dose intracorticosteroid plus a long-acting beta agonist. Or I can just put them on a medium-dose intracorticosteroid. So those are my options. An alternative treatment, I can put them on a low-dose intracorticosteroid, or I can put them on theophylline, that's an anti-inflammatory, or other medications. But what we usually do is always start them out stepwise here on the first one. So low-dose intracorticosteroid plus the long-acting beta agonist. Okay, so it was recommended we use the scenario with the step 3. I'm going to put the patient on a combination medication with the low-dose steroid. So remember, we have the intracorticosteroid, which is ICS, plus the long-acting beta agonist. That was our choice. Or I can do a intracorticosteroid at a moderate dose. and this was at the low dose. So how am I going to pick this? Thank goodness for this nice handy dandy chart. I used to have this actually hanging in my office. But anyways, how am I going to pick? So I'm going to go to combination medications, and I'm going to ask what the insurance they have. That's going to be a key factor. Or maybe they've tried medications before and they didn't like it. So there's different reasons why you're choosing the medication that you're choosing. So I'm just going to say, and I'm going to make this bigger, that I'm going to pick Advair right here. That's a common one. Hopefully it's covered by insurance. I would pick the low one would be 100 milligrams / 50 milligram. So the 100 milligram is your corticosteroid, the fluticasone, and then the 50 milligrams is your salmeterol, and that's your long-acting beta agonist. Patients really like that because they can feel that more immediate relief and through the day because they have that beta agonist, that bronchodilator in with the combination medications. But sometimes insurance won't pay for it, and we need to go to just a plain steroid. So what I would probably do is pick one of these. Again, in this area here, Qvar is commonly given. I would put them on at an 80 milligram. I don't know why my stylus is that thick. I would put them on an 80 milligram. You're just giving it plain. All these patients, though, need one of these on hand, so you always prescribe that. This is also in the guidelines. This is really nice because here again, it really puts it right out there for you. It tells you what dose to put them on. So if you're doing the fluticasone, MDI means meter dosed inhaler. It can tell you exactly how to take it. But I always use Epocrates, or I use UpToDate, or I use Micromedics to get my medication information from. Micromedics is an app that you can put on your phone, and I believe it's free. UpToDate always costs money, a lot of money, so if you're working in an organization, you usually will get that for free, which is awesome. Epocrates is fantastic app on your phone. There's a free version of that also. And that is it for asthma guidelines. Make sure you look through these, understand what the medications are, and if you have any questions, please ask your instructor.